I'm ready. Let's do it.
Okay. So the first thing I wanted to talk about is what you mentioned to me, and that is what's called IVF add-ons, which I had never heard it called that before. I know what it is, but I guess it has a term. So what exactly does IVF add-ons mean?
So it's basically this group of treatments that, in my mind, I lump together as being things that aren't essential. They're not the core part of IVF, which is stimulating the ovaries, extracting the eggs, making embryos, doing an embryo transfer. It is, extra testing or interventions that most of all haven't been proven in high quality studies, which are randomized controlled trials. And, there isn't robust data behind them. And I think it's hard because IVF is a very new field of medicine in the 70s, in the last couple of decades, and has improved success rates because it's a fast moving, growing technology. We're learning new things every day. And you always see the pendulum swinging from one direction to the next. Like a lot of people will jump on the bandwagon anytime there's a new shiny gadget or test or tool. And sometimes it turns out to be really helpful and it's shown in the data to be helpful. Sometimes we falls off of that bandwagon and moves on to the next thing. So we all want to have tools in our toolkit. And I think it's, important to strike a balance between trying new things but you have to balance it with not increasing the burden of treatment on patients, driving up the cost of their treatment. And some of these things might have harmful, unintended consequences or side effects. So, this is a broad category that can refer to things like endometrial scratching, which is, doing a biopsy to induce some healthy inflammation in the cycle preceding a transfer. And that was actually proven in a large randomized control study to not be helpful. And so most people who were initially excited about it stopped doing it. But I still get asked about it. And I think there still are clinics and doctors that are offering it or using it as a routine part of their protocol. And that just extends the treatment. And if we have good data that shows it's not helpful, and it's a biopsy, it is invasive, it's probably not dangerous, but I just think that there needs to be a good reason to do things like that. The ERA test is another hot topic that everyone keeps talking about. It's another biopsy of the lining, and they look at gene expression markers, and it's supposed to be informative and tell you if you need less hours or more hours of progesterone leading up to your transfer. And I just feel like that's a huge thing to change based on a test that went almost straight to market after very small studies with very small numbers of patients. So I just think we need more data. The ERA in particular is a hot topic because, it was initially thought of as being this test that can improve outcomes in people with recurrent implantation failure. And that's what it was really marketed towards. But now a lot of people are doing it preemptively before a first transfer. And a recent randomized controlled trial came out where they looked at that and showed no improvement in live birth rates in people doing this before their first transfer. So it's not something that I recommend.
Yeah, so it's kind of like the post that I made a few days ago about the whole thing with one study doesn't mean it's so. Just because something comes out, it sounds new and exciting, doesn't mean we should start doing it, especially when it comes to something like fertility and IVF protocols, because unless we have some good data that it's going to show that it helps. And I think a lot of times people think, well, if it's not going to hurt, then why not? But over time, we develop that data. When you're thinking about the process of IVF, the financial, the emotional, the physical investment and all that, we would really need to have some data behind that. So it's important to still ask those questions about these IVF add-ons. And you touched on a few of them, but I want to we'll go through a list of them and you just tell me what you think real quickly. Acupuncture.
Sure. So acupuncture, I think for some people, it really improves their quality of life. It relaxes them.
That's what it did for me.
Yeah. And I love falling asleep on the table. It's like a great feeling. It's not harmful. There's no study out there that shows that it can detract from your outcomes. So if you enjoy it and you like it, do it. If you don't enjoy it, if it's breaking the bank for you, you can't get it covered by your insurance and it's stressing you out, then leave it, because there isn't really robust data to suggest that it's going to make or break your cycle.
So I think if anything, for me at least, and at least from what I can tell from the data, it helps, if anything, with the stress aspect.
Yes.
And I think it's what, but I don't think it changed my uterus or my blood flow or anything like that. I think it was more for me just to help with the stress factor. Now, this is a hot topic. Pre-implantation genetic testing for aneuploidy. Now, let's go briefly through the different types of PGT, because there are different types, right?
Sure.
Okay.
Yes.
What are the different ones?
The main one is PGT-A, which stands for aneuploidy, which is a fancy way of saying an embryo with the wrong number of chromosomes. That's the number one way that it's used across the board. And if there's anything specialized being tested, it's always going to be counting the number of chromosomes, because that's a human problem. It's universal. Anyone can make an embryo with the wrong number of chromosomes. And even if you're 20, that can happen to 20 to 25% of your embryos. But there's additional testing that you can do. There's PGT-M, which stands for monogenic disorders. So let's say you and a partner both carry the cystic fibrosis mutation. You know that there's a 1 in 4 chance of having an embryo or a child with 2 copies of the actual disease. You can actually hone in and look for a certain set of mutations in the embryos. And that's a very specialized form of PGT. There's usually prep required where they build a specialized probe to look for that specific illness that you're screening for. Then there's PGT-SR, that's structural rearrangements. And that's to look for specifically embryos that might be affected by something called a translocation or inversion, where there's sections of DNA in the chromosomes and the way they're formed that are flipped or rearranged. And even though it doesn't cause a problem for the parent that has that rearrangement because they have all their genes, it can cause problems when their genes combine with their partner's genes, and there's a higher than expected proportion of abnormal embryos that form. And then you can do PGT for reasons of HLA matching, which is really rare. And I've actually never had a case of that in my career yet. Those are really the main forms.
Right. But it's important. I mean, it's good to know that there are different forms. And like Dr. Sekhon said, the main one that we all probably know about is PGT-A, which is what I had with all my embryos because of my age. So that's the one that most people, but I think what most people don't understand is the difference between PGT-A versus the PGT-SR, because we know we can do the PGT-A and get the numbers of chromosomes. It can tell you if you have the right numbers or you're having extra chromosomes or missing one within the different pairs. But then the PGT-SR looks within translocations with each one of those chromosomes. So that's how it's a little bit different. And usually for the PGT-SR, it's if there's a known, one of the partners is a known carrier for a translocation, correct?
Yes, and that's something that you can pick up in a karyotype. And that's a test that is specialized. A lot of people will assume, yeah, I did all my genetic testing. One should consider doing our expanded carrier screening. And that's looking at both prospective parents and seeing what mutations, if any, they carry. We all carry mutations. It doesn't matter because you usually have at least one functional copy of a gene. And that's to figure out if there's any risk of you matching for any of those mutations and having a child with 2 copies. That's different than a karyotype. Your doctor's only going to order a karyotype for specific reasons, usually recurrent pregnancy loss. If you did an IVF cycle and nothing turned into an embryo and you're young and that doesn't make sense, that's another reason to do a karyotype.
Okay. Okay. You already talked about endometrial scratching. What about adding growth hormone to an IVF protocol?
I mean, it's something that is regarded as experimental. It's not like an accepted treatment that is known to improve outcome of ovarian stimulation.
But what is it supposed to do? What is the purpose of it?
People think that it can help patients with a low response, a low ovarian reserve, patients who are older. They think that it provides some sort of boost to the way the ovaries respond and improves egg quality, but there's really no good data that shows that. And growth hormone can have some adverse side effects and outcomes. So, and in some states, it's actually considered illegal to use it, you know, if it's not indicated for its actual purpose, which is, you know, supplementing people that have a growth hormone deficiency. So, you know, in New York State, you're not supposed to be using it for that purpose. So we don't use it at our clinic.
Gotcha. Okay. Next would be assisted hatching. What is it and what do we know about it?
So assisted hatching is something that I think it's confusing because it used to be done on embryos to try to assist with implantation, make them more likely to implant. The embryo is in a shell that is inherited from the egg called the zona pellucida. And so the idea was, well, if we drill a hole into it or we digest it and thin it out with enzymes, perhaps it'll make the embryo more likely to implant. And that's really old fashioned. And now the only reason we think about doing assisted hatching in the lab is if we're doing a biopsy to test the embryos genetically. We need a certain number of cells to kind of herniate out. And it's almost helpful if the embryo is a little bit hatched. So we might do laser assisted hatching on day 3. And sometimes people do it on day 5 to help with the biopsy. And that's the only real reason to do it.
Gotcha. Now, some of the other things that someone was asking about steroid, like adding steroids or prednisolone to the IVF cycle. What about that?
Yeah, so there is a great ASRM committee opinion, or actually it's a task force document, and I was part of creating that. It took 2 years to review all of the literature, and we were all assigned to different things. I believe I was assigned to steroids and baby aspirin. So I've looked at all the literature for this, and the truth is, we know the immune system plays a huge role in implantation, right? It's very complex. You need your immune system to dampen and become relatively immunosuppressed in order for your body to accept an implanting embryo, which is at least half of its foreign, right? Because it's coming from someone else, whoever contributed the sperm. And so we know the immune system plays this permissive role. So there's this idea that, okay, well, people who are having problems with implantation, perhaps their immune system is rejecting this embryo. Right. So if we dampen their immune response further by giving them prednisone and steroids and IVIG, immunoglobulins, intralipids, we mess with their immune system and hopefully we'll tweak it in because there really are no good ways to test. There's no immune markers that are known to really tell us what's going on. Like, we know the immune system is important, but it's a major blind spot for us because I could run a bunch of immune markers and not really know what that means. You're right. And there are a lot of reproductive immunologists, which is kind of a field that's just been created where, people have looked at the different studies and they come up with their own cocktail and, they'll take you in, they'll charge you to do a bunch of testing and they'll give you a very detailed report. And I can't really comment on it because the data just doesn't point to some standardized method or approach. So have I had patients who, out of desperation after several failed cycles, have decided, they want to try prednisone, they want to go on steroids? I don't administer a lot of these things, but sometimes they'll seek a second opinion. And you know what? I'm going to be open-minded, but I always tell them this is what the data shows. And it's not completely inconsequential to be messing with your immune system either. Like, how do you know it's not dampening the response too much? Like, there's a healthy level of inflammation, right? Because that's what the endometrial scratch is based on. Right. So it's just, it's kind of like the blind leading the blind in this area. And it's frustrating because we know it's important. We just need to learn more about it.
Yeah, so it kind of sounds like some of the things with technology where they're supposed to look at what type, how the hormones are supposed to affect you individually, and there's no science behind it at all. It's a money-making thing. People do it with progesterone for preterm labor, and there's nothing, that says it works at all. So just be wary. And I understand because I've been in that situation. I understand the desperation when you've tried so many things and you're willing to try anything. I just want to take the moment, and I've said this before with both Dr. Sekhon on lives and other fertility specialists. You have to trust your fertility specialist. That is the number one person that you should go to. If you feel like you're starting to look into the fertility groups, you're starting asking questions, you're starting to wander outside, then there's something going on with that relationship there, and it might not be the right relationship. And, sometimes you have to find the right connection for you with your fertility specialist, and you might need to get a second opinion, but, your fertility specialist should know what you're doing and what you're seeking and what you're trying out. And if you feel like you can't tell them because you're afraid of what they might say, then that's, even more of a sign that something is going on. So it's really important that you have that relationship with your fertility specialist. You mentioned aspirin for IVF along with the prednisolone. What about the aspirin?
So baby aspirin is actually indicated if you know that someone has antiphospholipid syndrome, right? Some patients come to me with recurrent pregnancy loss and we find that those markers are elevated and we put them on baby aspirin while they're trying to conceive. And if they get pregnant, then we put them on Lovenox, and that's a proven intervention. Sometimes I'll have patients that want to go on baby aspirin during a transfer cycle in an effort to improve blood flow to the uterus. The data does not show any benefit,
No.
but I feel a lot better about that than people just willy-nilly taking Lovenox, which is a much more potent anticoagulant, which I worry about doing things like that with no reason. What if you fall and hit your head or get in a car accident? It's going to produce a much more precarious situation where you're going
even
to
the lower doses, and I've heard of patients getting it from other countries as well, and I will say you do not know what you're getting when you're getting it from other countries. You don't know the dosage is the right way, and that's, you know, and I've seen it happen a lot in my pregnant patients. I'm not a fertility specialist, but I've seen it on the other end, so be very careful about doing anything like that. Well, Amber, I wanted to ask you about embryo glue.
Yeah, that's not a thing. I mean, it was looked at a long time ago, and it was one of those things that became like a craze, but it never stuck around. No pun intended. But I've heard of people still doing it and talking about it. So the point is that this is an area that's highly unregulated, and it's kind of like the Wild West. Like, and you know, I hate to say this about my field because we've done so much that's good. But there's also a lot of gray areas, and I think it's because it's human nature to want to be the fixer and to have multiple tools in our toolkit. And I think that is a very natural tendency, but we have to be honest and say when things, you know, are actually rooted in evidence.
I 100% agree with that. Absolutely agree with that. Okay, I want to move on to a recent Instagram reel.